Hi guys, we shall now talk about AIDS, that is acquired immunodeficiency syndrome. First of all, they have asked in a one-liner MCQ regarding the definition. So anybody who's positive for HIV serology, and nowadays we do a fourth generation enzyme immunoassay for detection of AIDS. This fourth generation enzyme immunoassay will test for antibodies against HIV-1, antibodies against HIV-2, and P24 antigens. So this is more superior as compared to the older tests that was available. So if a person is positive for HIV serology and the CD4 count of the patient is reduced, then we'll definitely say that the patient is suffering from AIDS. With respect to the CD4 count, I want you to remember that if the absolute value is less than 200 cells per cubic millimeter, then the combination of the two would be called as AIDS. How much is the normal CD4 count? Approximately 800 to 1200 cells per cubic millimeter. You can take it an approximate of 1000 and lower the CD4 count, more sinister and serious the opportunistic infections would be developing in a patient. In one of the MCQs, what he did was that he did not ask the absolute CD4 count, that is less than 200. He asked that in percentage. So do remember CD4 count value less than 14%. Expressed as a percentage of the total white blood cells that are counted would be referred as AIDS, provided both things are positive, that is a serology with a CD4 count of less than 14%. You are aware of the fact that this belongs to a lentivirus genus. It's a retrovirus, and this is enveloped, as you can see on the left hand side. It has a proper group 120, which is the docking protein, group 41, which is going to be responsible for fusion. So I'll be describing the structure to you, but you can see that it has a proper envelope and it is a single stranded RNA virus. The highlight of this virus is that it has this enzyme by the name of reverse transcriptase, which is going to ensure that it can get converted from RNA to DNA and it can integrate with the host genome. For this, there's another enzyme by the name of integrase, but then thanks to integrase, because if this will integrate with the host genome, it will virtually be undetectable. Now, this is like a science fiction movie, like the virus or the burglar that enters into the security system. I mean, this virus has tropism for CD4 cells. CD4 cells are the security system. So he goes inside the security system and disables the security system by integrating into the basic circuit, and therefore it becomes undetectable, and the virus can lay down latent for years altogether. That is why normally, like HIV-1 infection, it takes 10 years for it to get converted into AIDS, or HIV-2, it takes 20 years to get converted into AIDS, because this has ability to fool the security system. It can integrate with the host genome. It will look like the host genome. It's hiding inside the host genome. So looking for this virus is like looking for a needle in a haystack, and that's definitely difficult. Well, when it comes to India, the AIDS epidemic began in 1986-87, where the first HIV infection was detected in Chennai. I have a handout from the NACO website only, which says that the first HIV infection was detected in Chennai, but the first AIDS case was detected in Mumbai. So that's an interesting piece of history that I want you to remember from the Indian domain. And let's just look at the caseload from a global perspective so that we can just have a better idea of what are we studying. According to the CDC website, there are 37 million, 1 million is 10 lakh, right? So that would be something in the range of over 370 lakh people who are living with AIDS. So people, or I'll just write it completely, people living with HIV. Of all the countries in the world, there's a country in Africa by the name of Swaziland, where the prevalence rate is a huge 27%. Now that was a very shocking, like for every 100 adults there are 27% people who are HIV positive. So well, God help this country. Thankfully India has been a little less afflicted with this global epidemic, and when it comes to India, it is 2.4 million people who are living with AIDS in India. So though PSM people might say 2.1, but most of the references that I found were giving a range between 1.9 to 3.4. Average was given as 2.4 million. So I would like you to stick with this data. And when it comes to high prevalence states, please remember in earlier times, the high prevalence state for this infection was mainly states like Manipur, but now if you read the data, it is Mizoram which is having a higher prevalence as compared to Manipur. So though the older data is Manipur, I would like you to recommend the latest one, that is Mizoram having a higher prevalence as compared to Manipur. And four states which are having maximum number of cases. I mean 55% of all cases in India are mainly in these four states, that is Maharashtra, that is the first one. Then are obviously Andhra Pradesh, Tamil Nadu, and Karnataka. These states are the ones which are relatively industrialized, in a sense that the economic growth occurred first in this part of India, and therefore with economic growth, obviously there was a lot of migrant population moving on, and then for taking care of the sexual needs, the prostitution rackets also came up. So because of this, I would say the incidence has been higher in these states since the industrialization. That's what is mentioned most of the time, that the industrialization has correlated with the growth of this epidemic in India. So earlier we were studying that Andhra Pradesh, Telangana is having the maximum number of cases, but now Maharashtra is having the max number of cases. You can check with your PSM faculty for the same also. And then would obviously be Karnataka and Tamil Nadu. These are the four states which according to the current data constitute about total of 55% of cases in India. When it comes to age group, the major age group that is affected in India is 15 to 49 years of age. That is obviously sexually active adults are the ones which are going to be affected, because the sexual route is the most common route of spread of this particular virus. So approximately 83% of total cases are in 15 to 49 age group, and 39% of total cases are females, and most of the time these females have acquired the infection from their husbands, or they might be commercial sex workers, where due to the demands of the customers, the protection may not have been used, and therefore these women have gone on to even produce babies who are HIV positive. And well, the goal of our country should obviously be the first one to make the vertical transmission rates go down to 0%, as America has been trying. So well, once we have remembered about the caseload per se, I would also like you to remember regarding the fact that HIV-1 virus, it will take approximately 10 years. That was a neat question, so I just repeated that again to get converted into AIDS. And HIV-1 is common in India, whereas HIV-2 is more common in Africa, and HIV-2 will take approximately 10 to 15 years to get converted into full-blown AIDS. So on a comparative basis, I would put it like this, that the Indian virus is relatively more dangerous as compared to the African virus, and this is obviously a global problem that all the countries need to come together to fight this particular infection. From the Indian perspective, from your PSM classes, you are anyway aware that HIV-1, Group M and subtype C is the most common type of HIV virus which is isolated from Indian population. So a lot of this information you are anyway aware from the PSM perspective, so this is a revision for you. And I would also like you to remember regarding a 90-90-90 approach, which is being used on a global basis. What they mean by the word 90-90-90 approach is the fact that 90% of the people who are living with AIDS should be aware that they are HIV positive. I mean, they should understand what HIV is, how did they acquire it, and how can they be transmitting this in the family, or how could they be, transmitting it to their children. So 90% people should be aware that they have a disease, they have a problem. Out of this 90%, the 90% of the total cases who are aware of the status, they should be on combination antiretroviral therapy, and those who are on combination antiretroviral therapy, that is CURT, they should also be having is a sustained viral remission. So 90-90-90 approach, I'll repeat once again, is 90% people should be aware that they have a problem. 90% of those people should be then the ones who are taking a treatment for the problem, and then 90% of those population who are taking a treatment should be having a sustained viral remission. That is, if you do a nucleic acid amplification technology or a PCR in these patients, then the count should usually become less than 40 copies per ml. I mean, we can identify as little as 40 copies per ml, which can be identified. And well, I have just shown you a couple of images for celebrities who have suffered from AIDS. One, I think you can identify Michael Jackson. Well, Michael Jackson died of a drug overdosage, and that was propofol. He used to take this propofol for inducing sleep. He died of propofol overdosage. But along with this is a rock star by the name of Freddie Mercury. That's not an MCQ, guys. Just to make you aware of the fact that in your college festival you would have all listened to that song "We Will Rock You." So that is a Indian chap who actually went abroad in United States. He became a rock singer, Freddie Mercury, and all of you in your college festival would have listened to this song very often. So I just wanted to tell you that this chap, he declared himself to be AIDS positive. He was a homosexual, and he subsequently died because of complication of AIDS. Then you can see a NBA star, that is Magic Johnson here. Both of these are celebrities in America who have died. He was an NBA star, and then you can look at a tall, strong, straggling, muscular chap ending up with AIDS, and then unfortunately, suffering from the impact of the disease. Obviously, the longevity with treatment with AIDS, we have ensured so much of dollars have been pumped into treatment for AIDS that we are ensuring, I would say, survival. But then the survival is not like a healthy survival like you and me would be having. So these people are always having that feeling that there's something wrong with my body, and that's very difficult to get away with. And then I came across a very unfortunate, I would like to say, information which I'm just sharing with you. This lady, she's an actress from Tamil Nadu. Her name is Nisha Noor, and she has acted with big stars like Rajnikant, Kamala Hassan, and unfortunately, she was forced into prostitution because of all this casting couch, etc. And then, unfortunately, you can look at the extreme HIV wasting that occurred in her. She unfortunately died because of that. So, there have been, people around us who have been unfortunately, I would say, who were very talented people who unfortunately died because of this infection. So that was just to get your interest into the topic that I have spoken about it, and we will now like to focus upon the major route of transmission of this virus. How is this virus transmitted? Coming to the route of transmission of the disease, well, the sexual contact is the most important route of transmission, just like hepatitis B. This is more important as compared to blood transfusion, and the incidence of blood transfusion has come down because of the fact that people have become more aware. People are now getting tested blood transfused, and obviously the government has also made it mandatory for blood to be tested before it is transfused into anybody else. So sexual contact is obviously the number one route for transmission of both hepatitis B as well as HIV, and obviously they ask you between homosexual, heterosexual, and heterosexual. And about the sexual act, I would like to highlight the fact that unprotected sex is obviously dangerous, but then unprotected receptive anal intercourse is having a chance of transmission of the disease up to 1 in 30. So instead of asking in percentages, nowadays I have come across questions where they've asked like chances and 1:100, 1:30. So I want you to remember that is unprotected receptive anal intercourse. URAI is the shortcut which is used by various textbooks to describe it, and the incidence is pretty high. In contrast, if I say unprotected vaginal intercourse, then the chances is that a male to female transmission versus female to male transmission, male to female transmission will be more effective because in a woman more surface area will be exposed. Unprotected vaginal intercourse, the chances of transmission are relatively lesser, and the textbook mentions between 1:10,000 for chances of transmission or development of HIV infection in the recipient. In contrast, the person who is in men having sex with men, insertive anal intercourse, the person who is the active partner, the insertive anal act can contribute to chances of transmission up to 1:1000, and that is same as with respect to oral sex, that is fellatio with ejaculation. Now, why am I discussing these activities is because lots of time I do get queries with respect to college students who are I would say college students who have had unprotected sexual exposure, and then they ask about what are the chances that I can get it. So for the various acts I mentioned it in not exact a percentage, but with respect to the data that I have shared with you, and then obviously they'll ask you regarding needle stick injury. In an accidental needle stick injury which is associated with recapping, the chances of transmission to a doctor according to the CDC website is 0.3%, but it is usually asked as 1:300 in some MCQs. And if it is needle sharing, like this guy, he went to a rave party where the drug peddler introduced him to IV drugs, and this young teenager thinks that doing drugs is a cool thing, then it is about 1 is to 1 is to 150. So I definitely want you to pay attention to the word needle stick injury versus needle sharing. With needle sharing having relatively, I would say, higher chances of getting infected as compared to needle stick injury. So doctors are obviously more prone for needle stick injury, whereas these college students, non-medical people, racy lifestyle, they are exposed to needle sharing. The incidence is 1 is to 150. With respect to blood transfusion, if infected blood is given to a recipient, then the chances of the recipient getting the disease is close to 95%. This happened in Tamil Nadu in 2019, that a college student, he had visited a red light area, he got infected, and then he was in the window period during which he donated blood. So because the blood was not tested properly, this blood was given to a pregnant lady and she turned HIV positive, and then all hell broke loose, and the media was sensationalizing the case and blaming the doctors for it. But blood transfusion with infected blood, there are 95% chances that if the bag of blood is containing the virus, then the recipient will definitely develop HIV infection. Now, on reading this information, the impression that comes is that HIV infection is very common with blood transfusion. The answer is no, because when the virus dies when it comes out of the human body, for it to be transmitted, the viral load has to be very, very high. Here it is clearly mentioned in a table from Harrison that there is only 0.121 chance per every million bags of blood, as compared to hepatitis B, where the incidence is relatively higher. So on a comparative basis, in a question, if they ask you that which of the following is the leading cause of transfusion associated hepatitis, you know it is hepatitis B. Obviously B is more common as compared to C, as you can see in the data for transfusion associated hepatitis. But if he makes you compare hepatitis B, C and HIV, and he says which has the highest chances of transmission, the winner is still hepatitis B. I repeat my statement. Leading cause of TAH, that is transfusion associated hepatitis, is hepatitis B. If they compare between B, C and HIV and they say which has higher chances of transmission, the answer should be given as hepatitis B primarily, because as you can see in the figure, it is about 1 per every 300,000 bags of blood, as compared to only 0.1 to 1 for every 1 million bags of blood transfusion being given to a patient. Blood transfusion is associated with multiple other infections also. So blood transfusion can be associated with transmission of dengue, Zika virus. That is important because Zika virus are discussed separately, but if a lady is Zika virus positive in the first trimester, then the baby can end up with development of microcephaly. West Nile virus can also be transmitted. Parvovirus B19, yes, the virus which is responsible for aplastic crisis and also responsible for slapchicks appearance in babies, that is erythema infectiosum, can be transmitted. Then is the trypanosoma, that is among the I would say tropical diseases which can be transmitted. Trypanosoma ehrlichia, some of the fancier names I would say. And then obviously syphilis and HHV8 can be transmitted via blood transfusion. So I mean the list is obviously huge, but I've just mentioned the important viruses which can be transmitted by blood transfusion, with Zika being important from your exam perspective, and then obviously tropical diseases like trypanosoma, ehrlichia. Syphilis is obviously, spirochetes are well known to be transmitted by blood transfusion. That is why in Government of India it is mandatory that blood should be tested against 5 antigens, that is HIV, hepatitis B, C, syphilis and malaria. I repeat again, HIV, hepatitis B, C, syphilis and malaria before the blood is transfused into anybody else. It is mandatory for blood to be tested for these antigens. And suppose, God forbid, the blood bank that you are associated with, the private blood bank that you are associated with, just because of cost cutting, if they don't test the blood properly and person gets the infection, then the responsibility is all yours. So obviously you have to be very, very careful whenever you are using services of any blood bank. And these are the important routes of transmission. You can see an unnatural sex will obviously be having a relatively higher incidence of transmission because of the tear in the anal mucosa. The recipient will be having a high chances of getting this particular infection. Now, once the infection will come in the body, let us see what will happen. And one of the obvious things that will happen in the body would be that the person's immunity will begin to go down, and therefore, once the virus comes in the body, the CD4 counts will begin to reduce. So let us practice. When the CD4 counts will begin to reduce, what's actually gonna happen in the how will the body of this person respond to this antigenic challenge of the virus attacking the immune system. You see, when there is a sexual contact, the dendritic cells which are in the mucosa, they are the ones which are the first one to be infected. So I'll put it like this: the antigen presenting cells, the dendritic cells which are present in the anal mucosa or which are present in the vaginal mucosa, they are the ones which are the first one to be infected, and then the infection obviously goes down into the lymph nodes, and the remaining CD4 cells also start getting infected. And in fact, in this condition, surprisingly, the infected cells and the non-infected cells both begin to die. That's again a very surprising fact, that infected CD4 cells are dying, understandable, non-infected ones are also dying. So when you will read up about this from pathology, you will notice the fact that apoptosis and pyroptosis, both of them are increased in patients who are having HIV/AIDS infection, and the exerted apoptosis and the inflammatory cascade, the pyroptosis, enhances the death of both infected as well as the non-infected cells in the patient, and as the CD4 cells would go down. So as the CD4 count will start reducing, we will say that person is in stage 1 when the CD4 count absolute value is less than 500 cells per cubic millimeter. On in percentage values, it would be given as less than 26%. We will say that person is in stage 2 of HIV infection when the CD4 count is between 200 to 499 cells. Now when it's hitting that value 200, zero VC infection, pneumocystis zero VC infection would start coming in, and the CD4 count of the patient will be in the range of 14 to 25%. We will say that person is in stage 3 when the CD4 count is less than 200 or percentage wise is less than 14%, and that is what I began the discussion with when I was teaching you regarding development of AIDS in a patient. That is usually stage 3 where the CD4 count is less than 200 and the percentage value is less than 14%. So there is a progressive decline in the CD4 count once the infection occurs in the body. And remember my words, both the infected and the non-infected cells will die. The infected cells die because of apoptosis, the non-infected cells die because of the pyroptosis component. So this disease is very peculiar in a sense that it has tropism for the security system of the body, right? The virus goes inside the DNA of the host, it integrates with the host genome, and therefore it lies latent there for years and years altogether, and then gradually it starts destroying these cells from within. So it's like a Trojan horse, I would say, that it's like a science fiction movie, that something goes inside the hard drive or something goes inside the computer system and then corrupts it from inside, and once the whole hard drive is corrupted, the motherboard is corrupted, the whole system is totally malfunctioning in the body. That is what is happening here also. This value of percentage is valid for children older than 6 years of age and adults. However, because they sometimes ask you for infants, especially for pediatrics, so for pediatrics the CD4 count, if it is less than 1500, where the percentage would be given it as 34% or lesser, would be classified as stage 1 of infection. If it is between 750 to 1499, then you would say it is stage 2 of infection, that would be 26 to 33%, and less than 750 cells, that is CD4 cells, or CD4 count absolute value less than 26% is taken to be stage 3. So do remember the cutoffs for stage 3 for pediatrics also, especially for infants. Two must know informations on this slide for you guys are: one, you need to remember CD4 count for adults, and CD4 count less than 26% for infants is considered to be stage 3 of HIV infection in a patient, and lower is the value, more is the problem for the patient. Another very interesting thing that will happen in this particular infection is that the incidence of cancers in the patient will start increasing, the malignancies in the patient will start increasing. So we read about what is called as AIDS-defining malignancies. AIDS-defining malignancies, to be remembered, are a total of 3, very straightforward. The first one is a vascular tumor which will originate from the endothelial cells, that is Kaposi sarcoma. The second one that is to be remembered after KS, Kaposi sarcoma, in AIDS-defining malignancy, to be remembered, is a non-Hodgkin's lymphoma, which is mainly a primary CNS lymphoma or PCNSL. I'll be showing you a CT or MRI head for non-Hodgkin's lymphoma, primary CNS lymphoma. And the third one is very surprising if you're reading it for first time, that is invasive cervical cancer. Yes, the invasive cervical cancer that you read with human papilloma virus 16 and 18 then can be associated with HIV infection also. So these are three AIDS defining infections, and the question that was asked was very easy. The question said which of the following is not a AIDS defining illness or AIDS defining malignancy, that is maltoma. You all know maltoma is related to Helicobacter pylori. So one, the CD4 count is decreasing, the incidence of cancers in the patient is increasing, and then this disease also causes the B cell dysregulation and causes autoimmunity to be upgraded. Very surprising indeed that the T cell activity is reduced and the B cell activity misfires. So B cell dysregulation is the word that I've said, which results in a development of a disease by the name of lymphocytic interstitial pneumonitis. I mean, this is obviously a rare disorder, but I want you to remember that in this condition, there is a B cell dysregulation producing antibodies which would be causing damage to the lung parenchyma. So the findings of those would be similar to that of interstitial pneumonia, where the person would be having a dry cough or a cough which would be lasting for weeks altogether, and you are looking for an infective cause, whereas there is no infective cause here. It is autoimmunity which is causing LIP, lymphocytic interstitial pneumonitis. Then the incidence of ITP, idiopathic thrombocytopenic purpura, is also increased in AIDS patients. They are not written it because obviously that is relatively less important. And then you will also notice that photosensitivity and allergic reactions with drugs, especially allergic reactions with trimethoprim and sulfamethoxazole, is increased in patients who are having AIDS, and that is secondary to the autoimmunity component. So from pathology, three domains I have said. CD4 count is on a downswing. The incidence of cancers is increasing, especially the AIDS defining cancers. And last but not the least, the B cell dysregulation can contribute to a lung manifestation that might look like that of pneumocystis jirovecii, and turns out there's no infective pathology. It is rather a lymphocytic interstitial pneumonitis which will respond to CARD, because as you upgrade the immunity of the patient, then the virus ability to cause B cell dysregulation will significantly be reduced, and therefore the clinical improvement in the patient will be seen. So once we remember these aspects, now let us look at how the virus structure is all about and how will the virus infect, and what is the first subsequent changes that occur in the CD4 cell once the virus is gonna get a hold into the nucleus of the CD4 cell, how the CD4 cell will respond to it, and what are the manifestations. Coming to the viral structure, the blue structure that you see here is called as GP120. This should be remembered as the docking protein by which the CD4 cell will attach itself to the CD4 receptor, and then with help of GP41, which you can see is the gray structure which is shown here, would be responsible for fusion of this virus with respect to the cell of the CD4, and then it will be able to inject its single-stranded RNA inside, and then with help of reverse transcriptase it will get converted to double-stranded DNA, which will then get integrated into the host genome. The blue structure which is shown here is the matrix protein. This matrix protein is referred to as P17, and inside this P17 is present the core antigen, which has been shown in color purple. The core antigen is the one which is P24. I want you to remember that for vertical transmission, the figures are close to 30%, and HIV PCR DNA is the best test to identify the vertical transmission. Why PCR DNA? Because the virus gets converted from RNA to DNA thanks to reverse transcriptase. So if the baby cells are infected, the provirus can be detected inside the body of the cell as early as 48 hours. So earliest detection of congenital transmission or vertical transmission of HIV is because HIV virus can cross the placenta and is majorly transmitted at the time of delivery. So if I want to pick up whether the baby is infected or not, the test to be done is HIV PCR DNA. Now when I was a student your age, then PCR was not such a valuable technique, so we used to do P24 antigen assay. That is the core antigen, and that is why we have spoken about it. And inside this you can definitely notice the single-stranded RNA virus. This single-stranded RNA virus would then get converted into DNA, and then the cells would get infected. So let's have a look at these four diagrams which are shown here before you. In the first one you can notice that GP120 is attaching to the CD4 receptor on the cell. Along with this, you can also notice a co-receptor. The co-receptor that is present here is called as CCR5. In fact, there are two co-receptors which are to be remembered. One is CXCR4, second is CCR5, and they are present on the CD4 cells. And what is the importance of these co-receptors is that they help in bringing about a conformational change, and because of the conformational change you will notice the fact that the virus will now come closer to the cell wall of the CD4. As you can see that the virus is coming closer to the cell membrane, so there's a fusion happening thanks to GP41. I'll repeat the steps once again. In the first diagram you can notice that there is only a docking which is occurring, so first diagram exhibits exclusively docking. Then with help of the co-receptor, that is CCR4 and CXCR4, there is a conformational change and the virus will come closer to the surface. So there is a definitive fusion that is happening in point number 2, and thanks to this fusion now the virus is ready to inject its RNA into the cell nucleus, where then this RNA which is injected would get converted into a double-stranded DNA. And this double-stranded DNA will then with help of integrase get integrated into the host genome and avoid the security system lie low for a long duration, which explains the latency period of this particular virus. You can see the importance of CCR5, which brings about a conformational change and helps in fusion of the virus with the CD4 surface, and therefore the virus is able to enter into the cell. There is a mutation which is by the name of CCR5 delta 32 mutation. Now what is the importance of knowing this is that people who are having this mutation, they will not be expressing CCR5, so the virus will be there in the blood but will not be able to enter into the cells. Now this is a boon for the patient because in a sense the virus is there but it's not going to attack the target cells, so the chances of person dying will definitely be reduced. So this rare condition should be remembered as hampering the infiltrative capacity of the virus. What I mean by infiltrative is the virus enters into the cell, then gets converted from RNA to DNA, integrates with the host genome. So hampering the infiltrative ability of the virus is a feature with respect to this particular mutation. And once the virus has gone into the cell, then obviously it will cause mayhem. So let us now study what is the problems that can be seen in the patient from the perspective of the opportunistic infections that will develop in the patient. We shall now be talking about infections which can be seen in patients of AIDS, where even if HIV serology has not been done or is indeterminate in a patient. I'll be describing total of 11 diseases to you in whom, if present in an individual, we can directly say that the person is having AIDS even if the serological tests are not available. In these 11 diseases, 6 will begin with alphabet C, 2 will begin with alphabet P, and then would be 3 alphabets H, K and M. So let's just talk about each one of them individually. The first one to be taken into consideration is Candida. Now do remember the fact that I'm not talking about Candida involving the oral cavity or Candida which is associated with like in pregnancy there is a vaginal candidiasis. We are talking about Candida involving the esophagus or the trachea or the bronchus and not related to the oral cavity or the vagina. That is the first thing to be remembered. An easy one. The second one is Cryptococcus neoformans. You are aware that Cryptococcus is usually shed in pigeon droppings. Inhalation of dust containing pigeon droppings can contribute to Cryptococcus infection, you and me also, with respect to the fungus feeding in the lungs. Now because immunity of yours and mine is good, the fungus would be killed by our immunity and we will not have any cryptococcal neoformans meningitis. But in AIDS positive patients, obviously because the immunity is less, the infection can go from the lungs to the brain. So he will either write the word cryptococcal neoformans meningitis, or he might just write the word extrapulmonary cryptococcus to highlight the fact that the disease has spread out of the lung parenchyma to the brain of the patient. The fungus has crossed the blood-brain barrier since the immunity of the person is less. The third C to be remembered is the one which is responsible for causing chronic diarrhea. Cryptosporidium parvum causes chronic diarrhea lasting for duration more than 1 month, which explains the wasting which is seen in patients of AIDS, especially HIV wasting is very severe. The emaciated appearance of the patient can easily be made out in the OPD. The fourth C to be remembered is cytomegalovirus. the cytomegalovirus will be contributing to development of colitis, or it could be contributing to esophagitis. Most of the time, the ulcers that are seen with cytomegalovirus are serpiginous ulcers. Traditionally, we read about serpiginous ulcers with Crohn's disease, but serpiginous ulcers involving the colon and the esophagus can be seen in AIDS positive patients, and these patients, even if the HIV serology has not been done or is indeterminate, we can still correctly call the patient as suffering from AIDS. The fifth C to be remembered is cerebral toxoplasmosis. This is an important cause of development of seizures in an AIDS positive patient. So if he says which is the leading CNS infection contributing to meningitis in AIDS, it is Cryptococcus. But if he specifies the word CNS infection contributing to seizures, now there are multiple causes of seizures in AIDS positive patient, but infection contributing to seizures should be remembered as cerebral toxoplasmosis. Coming to the 6C, it is a primary CNS lymphoma. So I'm just putting primary word in bracket at the moment so that you can remember the C's here. Primary CNS lymphoma is a non-Hodgkin's lymphoma. It would be a space-occupying lesion that can again contribute to development of seizures in an AIDS positive patient. So let us revise the 6 C's here. Candida, which is not going to be involving the oral cavity, Cryptococcus, Cryptosporidium, cytomegalovirus, cerebral toxoplasma, and CNS lymphoma. At this junction, you can see that coccidomycosis is not included in the list here, because coccidomycosis with positive HIV serology can be AIDS. Tuberculosis with positive HIV serology can be AIDS. Extrapulmonary TB with HIV serology positive can be AIDS. But here I'm talking about those infections where even if the ELISA test is not done, non-confirmatory, indeterminate response, we can still call the patient as directly suffering from AIDS. Now let us look at the 2 P's here. The first P to be remembered here is Pneumocystis jirovecii. This is rather easy to remember because this is commonly seen when the CD4 count of the person becomes less than 200 and it contributes to interstitial pneumonia developing in a patient. The next P to be remembered is progressive multifocal leukoencephalopathy, PML. The virus responsible for this is called as JC virus. JC virus is called as John Cunningham virus. Normally they name everything after the name of doctors, but this time they decided to call it after the name of a patient. So JC virus normally lives in our kidney in a symbiotic relationship. It is shed in the urine of a normal person regularly. But the same virus, when the immunity goes down, can contribute to damage to the brain. It causes mainly a white matter damage. It causes a subcortical white matter damage, which will cause hyper-intense lesions to be seen on a CT. So there are 2 P's to be remembered, that is Pneumocystis jirovecii and progressive multifocal leukoencephalopathy. So let us now talk about the remaining 3 which are left, that is 9, 10 and 11, which begin with alphabets H, K and M, so that we can just get the orientation right. The H would stand for herpes simplex esophagitis, or there could be a development of a mucocutaneous ulcer, which would be painful and would be lasting for a duration more than 1 month. Lots of time the herpes simplex esophagitis ulcers are punched out ulcers in the esophagus, which will cause extreme odynophagia. So odynophagia in a AIDS positive patient can be due to Candida, it can be due to cytomegalovirus, it could be due to herpes simplex virus, and herpes simplex mainly will cause punched out lesions present, whereas serpiginous is a feature with cytomegalovirus. Alphabet K will stand with Kaposi sarcoma, which is a vascular tumor. For it to be called as a AIDS case definition, it should be present in an individual less than 60 years of age. Obviously, it could be occur in older individuals also, but because AIDS is more common in people with reproductive age groups, so we're taking this cutoff. M would stand for MAI, that is Mycobacterium avium intercellular. So let us just revise the infections. There are 6 C's present, that is Candida, Cryptococcus, Cryptosporidium, cytomegalovirus and cerebral toxoplasmosis. It does not include the coccidomycosis component, which should be, if present, associated with HIV serology, then fine, that is a diagnosis of AIDS. But here, even without AIDS testing, we can say person is having a presence of AIDS, because these infections are, I would call as AIDS defining illnesses. Then there are 2 P's, jirovecii and progressive multifocal leukoencephalopathy, PML related to JC virus. The 3 more infections to be remembered are herpes, then is esophagitis obviously, then Kaposi sarcoma and Mycobacterium avium intercellular. MAI will commonly be seen when the CD4 count of the patient is less than 50. From the count perspective, do remember, if the CD4 count is less than 500, it is TB that comes in. When the count becomes less than 200, then it is Girovese. That is one of the leading infections which is present. When the count comes down to 100, it can contribute to seizures, that is cerebral toxoplasmosis. We will look at a MRI and a CT head of these patients and identify and differentiate it from neurocysticercosis. And if the counts come down to 50, then person can become blind. That is cytomegalovirus retinitis, or another one that is by the name of MAI, Mycobacterium avium intercellular. So these are the dangerous infections that can occur in these patients. The next thing to be remembered and can be seen from the image would be cerebral toxoplasmosis. In cerebral toxoplasmosis, unlike neurocysticercosis, the number of ring enhancing lesions will be fewer, and you will also notice that this will be having a slightly eccentric appearance, like you can see on one side. So whenever you read about what is called as eccentric dot sign on a CT or MRI head with respect to a ring enhancing lesion, then you have to think in terms of cerebral toxoplasmosis. You see, neurocysticercosis, you can go to the neurology part. In neurocysticercosis, the scolex of the worm can be seen. That would be bang inside the ring enhancing lesion. So in MCC, you would be able to see a lot of perilesional edema, and you will be able to see the scolex inside the developing larva, that is of cysticercosis allosae. But in this case, eccentric dot sign is very characteristic. The next thing to be remembered is cytomegalovirus. One, you can make out this is gut intestine. Why? Because you can see the goblet cells here. These are the goblet cells which are highlighted. And then you can notice, if I just zoom in, a cell which is having basophilic inclusion bodies. So cytomegalovirus is usually identified by basophilic, intracytoplasmic as well as intranuclear inclusion bodies, and we especially have some stains by which we can identify the cytomegalovirus infected cells, which can be used obviously to pick up the infection. But then cytomegalovirus colitis, cytomegalovirus pneumonitis or esophagitis is very specific. So these are the C's which are to be primarily remembered, and the last C to be remembered is the primary CNS lymphoma. In this non-contrast CT head, you can notice the fact that person is having a single lesion, the huge one that is shown here, and along with this you can see the black area, that is the cerebral edema component, and that will explain why seizures would be occurring. So the blood-brain barrier has been damaged, which will explain the seizures. So seizures can occur with the patients who are having cerebral toxoplasmosis as well as primary CNS lymphoma. How do you differentiate? Cerebral toxoplasmosis can be more than one lesion. Most of the time the area that is involved is the basal ganglia. To remember this small fact, that basal ganglia area, though any area can be involved, but basal ganglia is the area that's usually involved in these particular patients, and the eccentric dot sign would help you identify and multiple lesions obviously, whereas when it comes to primary CNS lymphoma, it would be single lesion with the extensive cerebral edema simultaneously present, which will explain the seizure component of the patient. In the next image, you can see perihilar shadows. This is a AIDS positive patient who has been coughing for past 2 weeks. Initially, I thought he could be having tuberculosis, but when I had a look at the X-ray, it is showing perihilar shadows which are bilaterally present. The oxygen saturation of the patient is disproportionately low, and when I did a bronchoalveolar lavage and I stained it with a gomorimethamine silver stain, then I can see these black cysts which are present, which are definitely indicative of pneumocystis jirovecii. And pneumocystis, the name is given because these cysts are present, and they can cause interstitial pneumonia to develop in a patient. The next image that is shown here before you is an MRI head which is showing presence of again a P, that is one is pneumocystis jirovecii, then is progressive multifocal leukoencephalopathy. Now this would be slightly difficult for you to pick up PML with respect to toxoplasma or with respect to, I would say, primary CNS lymphoma, which are single lesions. Here what is going to happen is that he'll always give you MRI and it will always be showing subcortical white matter lesions. These would be hyperintense subcortical white matter lesions. It is unlikely that he will give you a MRI head showing a PML in a patient, because even expert neurologists are not able to identify it, and the differentials usually first are for cerebral toxoplasmosis, which is less likely here because there is no circumscribed lesion, but it's a ill-defined white lesion all over the brain parenchyma, mostly presenting in the parietal lobe and the temporal lobe of the brain. Next, you can notice a presence of a solitary large ulcer in the esophagus, which is a feature of herpes simplex esophagitis. So unlike cytomegalovirus, where you could be having serpiginous ulcer, here a single ulcer could be seen, or a punched out ulcer can be seen with respect to the esophagus. So the patient again contributing to dinophagia in a patient. And the last image that you can see here is that of Kaposi sarcoma, which is a vascular tumor which is present in the oral cavity or can be present anywhere else in the body. I would also like you to remember a differential diagnosis of Kaposi sarcoma by the name of bacillary angiomatosis. This is going to be caused by an organism by the name of Bartonella henselae. You traditionally read about Bartonella henselae with cat's crutch disease, but Bartonella henselae is also incriminated in causing a lesion which might look like that of Kaposi sarcoma. There will be, I would say, reddish brown lesions present all over the body, and they can bleed on touch. Bacillary angiomatosis was not included in the initial AIDS case definition list because it requires a positive HIV serology. But if it is alone Kaposi sarcoma, even without HIV serology, it is included in the AIDS case definition, provided the age of the patient is less than 60 years of age. So these are couple of I would say images that can be given to you with respect to the important infections which could be seen with respect to AIDS. Okay, let us now just quickly revise regarding the life cycle of HIV before we go into the laboratory diagnosis of this disease. I have today explained to you the fact that this virus would be having a docking protein which is by the name of GP120. And then there is a transmembrane protein by the name of GP41, which would be helping the virus in the fusion with the cell wall of the CD4 cell. The yellow can be taken as representation for the CD4 receptor. And you need both the receptor as well as the co-receptor. So the blue is the representation for CCR5, that's the co-receptor. And when you have the docking, that is when subsequently the conformational change would be occurring in the receptor and the co-receptor, and this would help in the integration of the body of the virus with that of the CD4 cell. And then you can notice the fact that the single stranded RNA would be coming inside the CD4 cell. Now there is an enzyme by the name of reverse transcriptase which will come into picture, and what it is gonna do is that it will convert this RNA into a double-stranded DNA molecule. And once the double-stranded DNA is produced here, then this would go inside the nucleus, and now the role that will be played will be by help of an enzyme by the name of integrase. So you can remember like this RIP. R would stand for reverse transcriptase, that would be acting first for conversion of RNA into DNA. Then would be the activity of the integrase, and what the integrase would do is that it would splice up this host DNA. So I'll just modify the representation to say that if this is the host DNA, there's gonna be a splicing action here which I'm doing now, and then you would be having introduction of the HIV virus DNA. This would be the one that would be integrated inside. So you can see that now the virus is gonna utilize the nucleus as well as the capability of the nucleus to produce the daughter virions. Once the virus is integrated, DNA is integrated, then it will be producing what we say as messenger RNA. This messenger RNA will then utilize the host's rough endoplasmic reticulum, and it will be responsible for formation of new virions in this particular case. For formation of this new virions, obviously there are various proteins that are required, and the protein chains are fairly long. So to break those protein chains into smaller proteins, like I talked about P24, P17, so we need smaller proteins. So to form these virions, actually you need a third enzyme which is by the name of protease, and this protease will break down the longer protein molecules into the smaller protein molecules so that a mature virion can then be formed. And just for representational sake, I have here shown the budding of GP120 onto the surface of the CD4 cell, and very soon, this cell would be then having these baby virions, which would be released into the circulation and would be affecting the other CD4 cells as well. So you can remember from the sequence here, RIP, that is reverse transcriptase, integrase, and protease are three enzymes that will play an important role. And that is why when we talk about therapeutics, we have drugs that can affect reverse transcriptase, drugs which are gonna inhibit integrase or gonna inhibit protease. So we can basically prevent the natural life cycle of the virus and thereby achieve a control for this particular disease. Now, once we are sure about the life cycle, then I would also like to make you remember the fact that when it comes to infections like histoplasmosis, I did not include that in the initial list that I taught you. Why? Because histoplasmosis alone would not be sufficient for diagnosis of AIDS. You need a combination of the two, that is histoplasmosis with HIV serology to be positive, and then you say that okay, a person is having a development of acquired immunodeficiency syndrome. So for the common diseases like Pneumocystis jirovecii, which is one of the common interstitial pneumonia, even if the HIV serology is negative at the moment or has not been done at the moment, we say the person is having AIDS, but here you need a combination with HIV serology. Same is the status for HIV wasting and HIV encephalopathy. Now, why I'm emphasizing this twice is just to get you the fact that when you read these terms, they are very familiar terminologies that you have read in the book, but these all for diagnosis would require a combination of obviously this condition with HIV serology. Same is the case for tuberculosis. Same is the case with the extrapulmonary tuberculosis. So if somebody is having extrapulmonary TB, that does not mean that he's having AIDS. No, you need a combination of the two. So I have just made a list of those diseases which would not be included in the initial input that I taught you, where I spoke about like cryptosporidium, or I said that if a person is having cryptococcal meningitis, then that's obviously a AIDS defining illness, even in the absence of HIV serology. Now, what is this HIV serology all about that I've been talking about repeatedly? So for that, we will first talk about the tests which are available for diagnosis of this condition. So coming to the laboratory diagnosis of HIV, as far as the first test to be done is concerned, or the screening test to be done, that would be a fourth generation EIA, that is enzyme immunoassay. Now, the advantage of this fourth generation enzyme immunoassay is that it is able to identify antibodies against HIV-1. It is able to identify antibodies against HIV-2. And simultaneously it will also be able to pick up antibodies against the P24 antigen. So the diagnostic accuracy of this test, or the sensitivity of the test, or with respect to true positives, as you know, it is a huge 99.5%. so that is gonna help you in early identification of the disease. I would like to remind you the fact that when it comes to a third generation enzyme immunoassay EIA, the test used to turn positive usually by day 22 day of infection. Like I'll put it like this: a college student, he went to a red light area with his friends, just under peer pressure, and then under the peer pressure of his friends, just to prove his manliness, he had an unprotected sexual exposure, and now he's very worried. He comes to you, says, doctor, like I made this mistake and I want to know that whether I am having this infection. So we used to do a third generation EIA, and this used to be positive in 50% of cases by day 22, and the percentage of accuracy used to go up to 80% by day something like 42. For the older MCQs, I would like you to remember that window period for HIV infection was a range from 3 to 6 weeks. In 3-week period, that is by 21 to 22 days, 50% of cases usually used to turn positive, but most of the time you will notice that in the older MCQs, the window period is given as 6 weeks, because the diagnostic accuracy will obviously increase, the antibody titers will start rising. So almost 80% of the cases could be detected by 6 weeks after acquiring the infection. But you can see from this representation that if you want to identify the disease early, Then the test which is available before you is HIV RNA. HIV RNA starts getting or rather starts appearing in the blood in substantial amounts as early as the first week of the infection. So obviously, the PCR technique will help you in identifying it, or nucleic acid amplification technology would help you identify the infection. To cut the long story short, guys, the basic message is, if they say what is the best test for early identification of HIV infection due to exposure of the person to the virus, it could be anything like a IV drug abuse situation given, sexual exposure given, needle sharing given, then it is obviously nucleic acid amplification technology. So do remember the fact that if day 0 is when somebody got infected, then HIV RNA usually will be positive by day 12 in most of the cases, and you would be able to pick up the infection. And P24 antigen will start turning positive between the 15th to the 20th day, that is between the 2 to 3 week period. And then is obviously the older generation enzyme immunoassay which is available, and Western blot is going to turn positive something like 30 days onwards. The basic message is, for identification of this infection, we have to go in for a ELISA. Now, sometimes he might deliberately ask you conditions that might be causing a false positive ELISA, and this is also important because recently newspapers also, one guy was told that he's HIV positive, and later on turned out that that was a false positive report. So obviously your relatives or your patients can quiz you regarding what could be the reasons for a false positive HIV. So false positivity can be seen with some of the common situations, like one could be pregnancy, then could be influenza vaccination. These are two standard answers. In fact, the third standard answer, I'll also say blood transfusion. This is what most students are able to answer very easily: pregnancy, influenza, vaccination, blood transfusion. Apart from this, I want you to remember that if a person is having any autoimmune disorder, autoimmunity could range from something like SLE, scleroderma, then again false positive could be present, and even people with liver disease can be having a false positive ELISA. So these things are definitely to be kept in mind. So let us now see what does the CDC say with respect to the diagnosis of HIV. And if you look at this algorithm that I'm showing you on the slide at the moment, you will notice the fact that Western blot is not given here. So first and the foremost question that is asked by most students is that, we have read in PSM Western blot is used. I agree to that. NACO also says Western blot is to be used for confirmation. But here in the entire protocol, you can see that Western blot name is also not there. So we have to be very sure about what is to be answered in the exam. If he specifies the word CDC protocol for HIV detection and he says that what is the procedure to be followed, then the first thing that we will do would be a HIV-1-2 antigen antibody combined immunoassay. The word which is to be remembered here is combined immunoassay. That is a single kit. You are able to identify three things, that is antibodies against HIV-1, which is common in India, antibodies against HIV-2, which is common in Africa, and P24 antigen. And if it is positive, great. If it is negative, obviously you have ruled out the possibility of HIV infection in an individual. But now if this test combined immunoassay is positive, what is the next test that you will do in the patient? Then the next test is to be answered as differentiation immunoassay. So get my words right. The first test to be done is a HIV-1-2 antigen antibody combined immunoassay. That's the first test, the screening test. Now, if it is positive, the next test to be done is called as differentiation immunoassay. Meaning the word differentiation is obviously we want to differentiate whether it is HIV-1 causing the infection or HIV-2 causing the infection. And in majority of patients, this is the report that you will get, that HIV-1 will turn positive, HIV-2 will be negative. If this was situation like Swaziland or Congo or Kenya, countries in Africa, then HIV-1 differentiation immunoassay will be negative, HIV-2 will be positive. Very rarely it is possible that a person could be infected with, or person could be having a co-infection with both HIV-1 and HIV-2. And of the most important aspect in this table is that if both the reports are indeterminate, then what are you gonna do? So that's the MCQ statement for you, that a person has tested positive for 4th generation EIA. But when the differentiation immunoassay was done in the patient, then HIV-1, HIV-2 antibodies are coming the report as indeterminate. The test to be done is PCR/nucleic acid amplification technology. The nucleic acid amplification technology, which is now available, can pick up as little as 40 copies of viral RNA circulating per ml of blood. So if that accurate the sensitivity is for nucleic acid amplification technology, we'll definitely be able to know whether the person is having the infection or not. So if it turns out to be positive, great, we tell him that you are infected. If not, then obviously that's a lucky chap. I mean, you would tell him with a big smile that, well, relax, you are not having the infection, and the tests were coming as indeterminate, which could be due to the reasons I spoke in the previous slide, that is pregnancy, autoimmunity could be responsible for development of indeterminate, or I would say false positive reports in the individual. There is no role of Western blot in this entire CDC protocol. So let's get the words right. I'll just write the specific things before you. I am gonna order a EIA, a fourth generation one. So I'll just write the name once again. EIA, that is a combined immunoassay, and my person has unfortunately turned positive. So the next test I'm going to do in the patient is a differentiation immunoassay. That is, the EIA test would be repeated again. But in this differentiation immunoassay, we are very particular in a sense that we now need to know which of the strains of HIV is causing an infection. In case this turns out to be positive for either of the two, cool. If it turns out to be positive for both, very, very unlucky chap. But in case it is an indeterminate report here, so I'm writing I, indeterminate, then the third test to be done in the patient is NAT, that is nucleic acid amplification technology, which is also called as PCR. And if it is positive, then obviously you know that you are dealing with the infection and you were right in your approach with respect to the diagnosis of the patient. And if he's having early presentation, then this is the best way. Now let us look at what the NACO says, or Government of India says. He says in these circumstances, obviously the test remains the same, the ELISA test to be done, but then it is Western blot that is given. So if he asks in the exam what is the most sensitive test for detection, then you very well know that the answer should be given as EIA enzyme immunoassay. But if he says most specific test for HIV infection, then the answer should be given as Western blot. So in the CDC protocol, as I've explained to you, there is no Western blot given, and it is rather nucleic acid amplification technology that is used. And what does Western blot do? It rather picks up antibodies against all these antigens. Like for example, the antigens are group 160, group 120, then P17 matrix protein, P24. So all of these are encoded by 3 genes. You know that from basic sciences, so I'm not spoken about that. Is GAG, POL and ENV. Those are the genes, the 3 genes which basically code for all these antigens which are present on the virus, and the antibodies against these antigens can be easily identified by the Western blot test. So they can give you a picture like this and they can say that what test is being done in the patient. So in this case, you can see with help of the names written very easily, you can pick up that this is a Western blot which is being done for identification of infection in the patient. Once we've identified the disease, we'll also be doing other tests in the patient in the form of CD4 count. As compared to CD4-CD8 ratio, CD4 count will give you more diagnostic importance or information for this, and lower the CD4 count, higher the chances of opportunistic infections occurring in a patient. You very well know the fact that nowadays we don't have any cutoff of CD4 count below which we will be starting the person on combination antiretroviral therapy. There's no cutoff according to the NACO guidelines currently, and even that is what the UNAIDS and international organizations are also saying, that I mean, why do you want to let the patient suffer? You see, the CD4 count will decrease, then opportunistic infections will occur, and there is a common sense to it, because when opportunistic infections will occur in an individual, the cost of treating them is much more than the money that you will spend in providing him with combination antiretroviral therapy before he actually suffers from the disease. So the objective is, good health of an individual. You let him suffer and then you say, okay, I'm going to treat you. It's better to actually prevent all these manifestations from occurring in a patient. So most of the time, with help of CD4 count, we are gonna definitely know the progression of the disease. We also write LFT for the patient. Why? Because a lot of these drugs actually damage the liver. Like nevirapine is one molecule that can definitely cause a fulminant hepatic failure. So we would like to go in for a LFT. Lipid profile is also to be done because the cardiovascular complication that is most commonly seen in HIV is myocardial infarction and coronary artery disease. So a baseline lipid profile and blood glucose would obviously be done in the patient. Another test that I would like to do in the patient is a nucleic acid amplification technology, HIV RNA. This would tell me exact number of viral copies present per ml of blood. So if he specifies the word sensitive test, 4th generation EIA, he says specific, it is Western blot slash, if he says viral load is best determined by, then the answer is HIV RNA. The only time you are supposed to answer HIV DNA is with respect to vertical transmission of HIV. If he specifies the word, like a lady, she has delivered a baby, she was HIV positive, and you would like to know the status of the child in the first few hours of life or as early as day 2 of life. You want to know whether the baby is infected or not, because you see the chances of transmission are only 30%. So not every baby who's born to a HIV positive lady will also be HIV positive. So to identify, we will be going in for HIV DNA for vertical transmission of the disease. The next test that I will write for the patient would be like VDRL. That could be to pick up any co-infection that could be present in the patient. Then obviously hepatitis B, hepatitis C, D and G also have to be evolved. And here I would like to say a very interesting fact that you would have read in books also, that if hepatitis G is present as a co-infection with HIV virus, then with hepatitis G for Greece, the progression of the HIV virus is relatively slower. You see, traditionally what we find is that when HIV is present with, let me say, hepatitis C, then hepatitis C course becomes relatively more severe. It causes more chronic hepatitis, faster progression to cirrhosis. But here I'm saying a very surprising fact, and that is why it's an MCQ statement, that HIV viral progression becomes slower with which virus? Then answer would be hepatitis G virus. Then I would also like to do a PPD, that is a purified protein derivative, or a Mantoux test in the patient. Why? Because I want to identify any possibility of latent tuberculosis being present in a patient. And if latent TB is present, then isoniazid and pyridoxine needs to be given to the patient. Another test which is of importance is antibodies against toxoplasma, because you see a lot of patients of HIV can be having seizures. If a person is having anti-toxoplasma antibody, then the chances of him having seizures are even relatively higher, because he is already exposed to the disease. And you see, toxoplasma manifestations are like tuberculosis. Like TB occurs in the form of reactivation, like in adult you have reactivation of tuberculosis. Similarly here, toxoplasma reactivation of a latent infection will cause more severe manifestations in a patient. The chances of a person having CNS complications increase if he is already exposed to the disease. So anti-toxoplasma antibody, immunoglobulin G, if it is present, that means that I have to be more aggressive in my treatment since the person is already exposed. Then you know that HIV virus can cause dementia. It can contribute to damage to the neurons. So we have HIV dementia developing in patients. So a baseline Milley mental score examination, or MMSE, should also be done in the patient, so that we can monitor and compare with the last year. Like if I have a MMSE score of this year and then the next year, then I can see if there is any cognitive decline with respect to the patient. And again, the test to be done in a patient, I'll repeat once again, are 4th generation EIA, Western blot, a nucleic acid amplification for viral load, then a host of other tests, so that we can pick up the coexistent conditions with respect to this virus. And well, there's a new test which is available for HIV infection now. What I mean by new test is a new kit which is available, which is a oral kit available. I've just shown a picture here before you of a brand by the name of OraQuick. Now, who are the groups where you would use this? You see, some people who have actually got the infection, they might feel very shy walking into a laboratory and then getting themselves tested. They will say that everybody will come to know of it. The laboratory technician belongs to my community. Maybe he will spread the news around that I was getting tested for HIV. So I mean, different people, different reasons. So OraQuick is a test which can be done by the patient at home only if he suspects that he is exposed to HIV virus. And this test can be done both on saliva as well as on blood. The diagnostic accuracy with the blood is close to 99%, with saliva is about 98%. So it is a good test for those people who don't feel very comfortable walking into a laboratory, just because they have this impression that the whole world would come to know of this. And you know nowadays that HIV infection, we should not, obviously, be, as doctors, we do not discriminate, but in the community there's a lot of discrimination present. So the longevity of persons who are having HIV infection is increasing on a daily basis, because we have done so much of research and development in this particular disease that the chances of person dying is very, very less. And how do we ensure that? Because we know that the person is infected, we know that his CD4 count is going to decline. So most of the time we are going to start prophylactic medicines for the patient, and these prophylactic medicines are going to improve the longevity. It is going to improve the lifespan of an individual. Like if the CD4 count is decreasing, to maybe 20% or normal, I'll not let the person develop a zero VC pneumonia and come to me. For prophylaxis of pneumocystis jirovecii, the antibiotic that we use in the patient is cotrimoxazole. So cotrimoxazole is not only the drug of choice for pneumocystis jirovecii, it is also used for prevention. The double strand tablet is also used for prevention and for toxoplasmosis also. The answer is the same. If he says what is the best way to prevent cerebral toxoplasmosis in an individual, it is cotrimoxazole, again a double strand tablet. In fact, I would like to make a reference here to the fact that cotrimoxazole is answered 3 times in HIV. One, it is the drug of choice for jirovecii. It is also used for prophylaxis of toxoplasma. In jirovecii, it is both for treatment as well as for prevention. In toxoplasmosis, it is used mainly for prevention. If a toxoplasmosis patient is already having encephalitis, then the answer should be given as pyrimethamine. We usually combine pyrimethamine with sulfadiazine and leucovorin. The combination can contribute to severe folic acid depletion in the patient, so that is why we are having a addition of leucovorin in this combination. When would you decide to start pyrimethamine and when would you decide cotrimoxazole is based on antibody profile? If the person is already having an exposure to toxoplasmosis, then the manifestations are more severe. So if IgG class or toxoplasma antibody is positive, we usually start with pyrimethamine sulfadiazine, and in case the person is negative for IgG class of antibody, we start with cotrimoxazole. For cotrimoxazole is 3 times with respect to 3 infections. Perspectives can vary, like jirovecii, cotrimoxazole for both treatment and prevention, toxoplasmosis for prevention, cotrimoxazole double strand, and then there's an infection by the name of isospora that can contribute to chronic diarrhea. Like cryptosporidium can cause a chronic diarrhea in HIV positive patients. Even isospora can contribute to development of diarrhea, and that is where we use cotrimoxazole for treatment. And when I discuss the GI diseases seen with HIV, this would come up again. Now, if a person of HIV is having PPD, that is purified protein derivative Mantoux test positive for more than 5 millimeter, it indicates the fact that patient could be having a latent tuberculosis infection, LTBI. What is the treatment for latent tuberculosis infection? You have to give isoniazid to the patient along with vitamin B6, that is pyridoxine, for total of 9 months. Mark my words there. Total of 9 months, we will be giving only single antitubercular drug isoniazid with pyridoxine for person who's having latent tuberculosis infection, because you see, when you are gonna not manage tuberculosis, TB can definitely turn lethal. In fact, 30% of mortality with respect to HIV infections occurs in cases who had tuberculosis or had latent TB. It was not picked up by the doctor and then the person developed miliary tuberculosis. Unfortunately, the patient expired. There are 2 ways to pick up latent tuberculosis infection. One is purified protein derivative showing a reaction of more than 5 millimeter in the forearm after 48 to 72 hours. Second is interferon gamma release assay IGRA. Or a third situation when latent TB could be present is somebody in the family is having active tuberculosis. Now that's very common in India, that let me say this HIV positive young chap's father is being treated for tuberculosis. So contact with the open case of TB is again where this guy could be developing a latent tuberculosis which could turn lethal subsequently. For Mycobacterium avium intracellular, for prophylaxis, the antibiotic to be remembered is clarithromycin. This is combined with ethambutol. So do remember that for MAI, Mycobacterium avium intracellular, we are not using rifampicin INH, we are using ethambutol with clarithromycin. The third drug that may be added for Mycobacterium avium intracellular infection and for prevention is rifabutane. So again, I highlight the fact that we are talking about prevention of these infections in an individual. Like a HIV positive patient was exposed to somebody with chickenpox, like a child in the family developed chickenpox. So I will start giving the patient straight away varicella zoster immunoglobulin to prevent development of a fulminant chickenpox and bleeding manifestations. For cryptococcosis and coccidiosis, the antibiotic that is given for prophylaxis is fluconazole. But if he says which antibiotic is best for prophylaxis against histoplasmosis, then the answer should be given as itraconazole. People with HIV are also exposed to gram-negative infections, especially salmonella. For this, if he has already suffered from a bout of diarrhea, and salmonella was demonstrated as one of the reasons, or the person with HIV was diagnosed with typhoid, then ciprofloxacin prophylaxis should be used in the patient. Bartonella Hensley can contribute to cat scratch disease. For prevention against this, the antibiotic to be used is doxycycline. Last but not the least is cytomegalovirus. For CMV, we have to remember there are obviously multiple ones. One we can use is valcyclovir or acyclovir. So valcyclovir, like I'll write once first, can be used, or acyclovir can be used in the patient. So by using this prophylactic techniques, we are able to enhance the survival chances, and obviously, along with that, combination antiretroviral therapy will play an important role. I would also like to state the fact that if tuberculosis has been diagnosed in a patient of HIV or AIDS, then first we have to give treatment for TB. Don't answer as AIDS treatment first answer as TB treatment. Why? Because when you treat tuberculosis, first you decrease the viral load, bacterial load in the body, so the chances of IRIS, that is immune reconstitution inflammatory syndrome, will become less. The NACO guidelines are, if TB and AIDS are present together, first you are supposed to start TB treatment, then after 2 weeks AIDS treatment. So I repeat again, first TB treatment, then after 2 weeks AIDS treatment, not the reverse. Don't answer as first part followed by anti-tubercular treatment. And I'll talk about this again when I speak about the respiratory infections which are associated with HIV infection. Then what are the vaccines that should be given to HIV positive patients? So the vaccines to be given are definitely hepatitis A and hepatitis B. Along with this, another vaccine which should be used in the patient is pneumococcal conjugate vaccine, that is PCV13. We can give a booster of 23 valent vaccine, but first vaccine to be given for bacteria, because the most common respiratory infection in HIV positive patients, let me be very clear, the leading respiratory tract infection that occurs in AIDS positive patients is not Girovacin, it is pneumococcus, because the infection will come from community. See, the person should have a CD4 count decreasing to 200, then Girovacin will come. But otherwise, if the CD4 count is 800 or 700 or 600, then it is pneumococcal pneumonia that is more common. So it is pneumococcal conjugate vaccine that would be given to the patient. Then even the vaccine for human papilloma virus, because invasive cervical cancer is a AIDS defining illness. So human papilloma virus vaccine, HPV vaccine, should also be given for AIDS positive patients. This will definitely reduce the morbidity of the disease and the mortality of the disease. So we are doing a lot of things in patients of AIDS apart from combination antiretroviral therapy, so that we can increase the longevity of these patients. So coming to discussion on respiratory diseases that are found in AIDS positive patients, I would like you to remember the fact that incidence of pneumococcal pneumonia is much more than that of tuberculosis. I have said earlier that TB is a leading cause of mortality, but now I'm talking about incidence-wise infection. So pneumococcal pneumonia is more common as compared to TB, as compared to pneumocystis jirovecii. Do not be surprised at this information, because in older books they used to talk mainly about Girovacin, because earlier we used to wait for the CD4 count to fall, and then we used to start combination antiretroviral therapy. But now we are starting combination antiretroviral therapy irrespective of the CD4 count in the patient. So the incidence of Girovacin pneumonia will obviously go down, because when you start CART, it definitely kills the virus, and the CD4 count definitely remains usually in upper limit of 500 or so. So the chances of person dying or developing Girovacin pneumonia per se as a incidence wise information has significantly reduced. You can now see two x-rays with respect to the left side of the slide. So I would like to highlight the fact that if they mention that the patient is HIV positive, they'll give you history of maybe 2 weeks, deliberately maybe 4 weeks, cough, shortness of breath, dyspnea, etc. And you can notice bilateral perihilar opacities in this patient. So out of the 3 infections which are given, you should then answer as Girovacin. Why Girovacin? Because when it comes to pneumococcal pneumonia, it will mainly produce consolidation or patch in one lobe of the lung. Like if in the same x-ray you could notice one big patch, then you could have thought in terms of pneumococcal pneumonia. But here you are not having one patch of consolidation, it's bilateral perihilar opacities. In Girovacin infection, in early part even x-ray can be normal, but as the disease will progress, obviously bilateral perihilar opacities will develop. And then if you look at the inferior x-ray, you can notice multiple spots present in both the lung fields in the patient. So this untidy looking X-ray that I've shown before you is suggestive of a miliary picture, which is seen with patients of AIDS, because in AIDS we will usually find the dissemination incidence tends to increase. So if you are having this miliary kind of an appearance or a snowstorm appearance present in an X-ray, bilateral lung fields are hazy bilaterally instead of only focusing in the perihilar area, then tuberculosis should be given as an answer. And there are three domains that I want you to remember. First of all, incidence wise data, pneumococcal pneumonia more common as compared to Girovesi. Only bilateral perihilar infiltrates, then it is Girovesi. If it is a hazy appearance, then you should think in terms of possibility of tuberculosis in a patient. In most of the questions, the history that would be given to you would be that of mainly fever, shortness of breath. In fact, sometimes you might just say that the person is experiencing chest pain and feels uncomfortable for most part of the day. So in these patients, we obviously have to do a chest X-ray. As I said, X-ray can be normal initially in all the three conditions. But if he specifies the word perihilar, then you should think in terms of Girovesi. Other information that can be given in the question in favor of Girovesi could be that he might mention that the LDH values in the patient are elevated, which is not the information that is provided in others. Then there's a test by the name of beta-1,3-glucan test. Though I've spoken about this beta-1,3-glucan test multiple times, I want to remind you that this is positive in Candida infection, it is positive in Aspergillus and Pneumocystis jirovecii. So beta-glucan test will definitely turn positive in the patient. If you are gonna check DLCO, that is diffusion capacity of the lung for carbon monoxide, because there is interstitial pneumonia in the patient, the DLCO of the patient will significantly be reduced. And if I do a BAL, that is bronchoalveolar lavage, then this will be stained either by right Giemsa. So we are not gonna use a gram stain. Either he will say right Giemsa, or he might talk about methamine silver, or he might talk about fluorescent staining that is available nowadays. So if this is the kind of information given, then you can understand that I'm talking about Girovecii in a patient. For management of Pneumocystis jirovecii, the antibiotic of choice is cotrimoxazole. If the person cannot tolerate cotrimoxazole or there is an allergy to cotrimoxazole, we can also be using intravenous pentamidine. Do not be surprised, because pentamidine is useful for prophylaxis of this infection. It is given as a weekly nebulization for prevention, but intravenous pentamidine is also recommended in case the person is allergic to cotrimoxazole or allergic to sulfur drugs. Then use of steroids is also mentioned for management of Girovecii infections. This is to mainly reduce the iris component, that is immune reconstitution, inflammatory syndrome, and steroids are usually given when either of the two informations are given in the question or are present in the patient. One, on the ABG, if the PO2 values is less than 70, that is severely hypoxic patient, we will have to use steroids in the patient. Second, he might write the word A-A, that is alveolar arterial gradient more than 35. How much is the normal alveolar arterial gradient? Then it is about 15 millimeters of mercury. That is, gas diffuses across a gradient from our alveoli to blood vessels. And if there is a interstitial pneumonia present in a patient, then the ability of diffusion will be lesser. And if the gas will diffuse less, then the gradient will increase mathematically. So enhanced gradient, PO2 less than 70, they all indicate severity of the disease, where steroids would be useful for management of the patient. So this information that I've highlighted in the box is specific to diagnosis of Pneumocystis jirovecii. Tuberculosis is a separate lecture, so as such I have not spoken much about tuberculosis with respect to AIDS in this particular slide. I'll do talk about tuberculosis in the next one, but for this information in the red box, you should think in terms of Girovecii pneumonia in an individual. Now do remember the fact that Girovecii can have a extra pulmonary manifestations also. So that is again a question that I came across, or a student put up before me in the group, that what is the extra pulmonary manifestation with Girovecii. So it can cause lymph node enlargement, lymphatic enlargement. It can even present as a otic mass. That looks very surprising, but it would be a otic mass of Girovecii in the external meatus of the patient. Apart from this, obviously, involvement of the lymph nodes, involvement of the liver in the spleen, resulting in hepatosplenomegaly, can also be seen with pneumocystis jirovecii infection. Even ophthalmic manifestations in the form of a lesion in the choroid can also be mentioned. Just to get the record straight, when it comes to Mycobacterium tuberculosis, MTB, Mycobacterium tuberculosis manifestations become more severe when AIDS is present in a patient. In Mycobacterium tuberculosis with AIDS or HIV infection coexistent, the cavity size will be relatively smaller. The chances of dissemination of infection will be relatively more, so extrapulmonary TB manifestations are more in patients who are having HIV with tuberculosis. Dissemination chances is more and cavity size is relatively lesser. For treatment of patients, if two things are present together, HIV as well as tuberculosis, we are supposed to give anti-tubercular treatment to the patient. Then we are also supposed to give combination antiretroviral therapy to the patient, and the time lag between the two should remain as 2 weeks. The reverse would contribute to iris. However, for latent tuberculosis, I've already explained to you, you will identify on the basis of Mantoux test, and if required in the patient, if Mantoux is more than 5 millimeter report, then isoniazid with vitamin B6 pyridoxine should be given for 9 months. They love to ask about mycobacteria, even the atypical mycobacteria, that is MAI, Mycobacterium avium intercellular. Now, when it comes to MAI in a patient, this organism is ubiquitous in the environment. I mean, it's present everywhere in the environment. Even we could be inhaling it, but it will not cause problems in you and me because our immunity is good. But in AIDS positive patients with CD4 count of less than 50, then the incidence of MAI will definitely increase in the patient. The portal of entry will obviously be via the respiratory route, that is via the lungs or via the GI tract of the patient, and as I said, this organism is present everywhere. The chest X-ray findings of Mycobacterium avium intracellular will again be presence of bilateral infiltrate. This will be little difficult to identify from the miliary tuberculosis that I was talking about earlier. So to differentiate between the two, one, you will obviously be having an idea from the CD4 count, because at 500 you have tuberculosis, at 50 you have higher chances of MAI. Though I'm not saying that at 50 tuberculosis cannot occur. So how would you differentiate? We do a culture. Now the culture that is recommending here is either of BAL, that is of bronchoalveolar lavage, or we can obviously do a culture of any respiratory secretion. If not available bronchoalveolar lavage, then bone marrow biopsy is also recommended in these patients, and even a blood culture can be done in the patient because the infection is going to disseminate very severely. You see, CBNAT for tuberculosis has turned negative. What I'm saying is CD4 count is less than 50, CBNAT for TB is negative, and X-ray is still showing bilateral infiltrate, which looks like that of miliary TB, then it can't be tuberculosis. I repeat my statement again. You see, the person is having CD4 count of less than 50. X-ray was showing a miliary picture. You thought it could be pulmonary TB, it could be atypical mycobacteria, and the test for TB is negative, then it could be definitely a possibility of atypical mycobacteria in the patient. And therefore, for management of these patients as well as for prophylaxis of these patients, the antibiotics that we use are clarithromycin. And it is mainly for the antibiotic choice that he is going to quiz you here for MAI, both prevention and the treatment part, that we are not using rifampicin for atypical Mycobacterium INH. We are rather using clarithromycin with ethambutol. Additional drug that may or may not be used for management of this patient is rifabutin. So it's mainly the drug treatments in opportunistic infections in AIDS positive patients that are asked. So do take a or do keep a watch for it. Then in some cases, he might just give an X-ray that might again be having a hazy appearance in bilateral lung field, but no organism has been isolated. If none of these organisms that have been isolated, I mean, it's not pneumococcal pneumonia, it's not TB, it is not jirovecii, it is not Mycobacterium avium intercellular, and even test for histoplasma antigen in the urine has turned negative. I mean, you tested for coccidomycosis, you tested for histoplasma, and all routine fungal infections are negative. Then the diagnosis of occlusion would be LIP, that is lymphocytic interstitial pneumonitis. This condition mainly occurs due to B cell dysregulation, which is found in HIV positive patients. Here it's only that there would be an antibody mediated damage to the lungs, so the X-ray would be showing a picture of a hazy bilateral lung fields or bilateral infiltrates which are present. But obviously for diagnosis of this condition, all the infective conditions should definitely be ruled out. And To finish the respiratory infection component in AIDS, I would like to say the fact that invasive aspergillosis. You see, Aspergillus have taken a separate lecture on it because it's obviously important, and we read about ABPA, allergic bronchopulmonary aspergilloma. So ABPA is common with cystic fibrosis. ABPA is common in asthmatics, but it is not seen with AIDS positive patient. So in this entire discussion, invasive aspergillosis has not come, and that is itself a question that which of the following infections, like options would be histoplasmosis, coccidomycosis, Mycobacterium avium intercellular, and aspergillosis, and you'll say which of the fungal infections is not seen in AIDS positive patient. So usually not seen in AIDS positive patient, then the answer should be given as invasive aspergillosis in the patient. The next thing that we shall study is cardiovascular associations in AIDS positive patients. For finishing the respiratory part, I would just like to say that cardiovascular perspective, it is myocardial infarction risk that is increased in the patient, and HIV cardiomyopathy could be present. So baseline lipid profile is always a good idea. Then we will talk about GI associations or GI diseases which are found in AIDS positive patients. Most of the time, the GI diseases that can be asked are oropharyngeal candida. In the first handout given to you, or in the left image on the left hand side, you can definitely notice thrush present, oropharyngeal candida present. Now, oropharyngeal candida itself is not gonna be diagnostic of AIDS, but obviously it can spread and it can involve the trachea and the bronchus in the patient. So the question might begin by saying that an AIDS positive patient is presented to you with odynophagia. Whenever he says like this, AIDS positive truck driver presents with odynophagia, you have to think in terms of esophageal candida in the patient, and then admit the patient because he will not be able to take orally. So for esophageal candida infection, you will have to give intravenous fluconazole to the patient. Once it's better, he can obviously take oral. So in the first image, there is obviously a presentation of oral thrush, but it can spread further in the individual and involve the respiratory tract, lower respiratory tract to be precise, and obviously the esophagus. The next image, which is or a GI association, because mouth is also part of GI to be remembered, is black hairy tongue. Now the virus which is responsible for black hairy tongue is Epstein-Barr virus. In this condition, there is an enlargement of the filiform papillae of the tongue. Though there are lots of causes of black hairy tongue, and it could even be seen in cigarette smokers, but then because it is described in HIV infection first, so I just want you to remember black hairy tongue caused by Epstein-Barr virus. In fact, why is it asked is like you are aware that Kaposi sarcoma is not caused by HIV virus. Kaposi sarcoma is caused by HHV8. Here, black hairy tongue is not caused by HIV virus but is caused by Epstein-Barr virus. So as the immunity decreases, obviously these viral infections can be present. And then he can mention regarding chronic diarrhea in an AIDS positive patient. Now, in a chronic diarrhea in an AIDS positive patient, you will be going in for what is referred as a modified ZN stain. There are two possibilities on a modified ZN stain. Now have a look at them. In one of the presentations, you can see that the cysts which are seen here are very small in size. You can see the cysts which are present are usually less than 10 micron. On the other hand, on the right hand side, the image, they are almost double or triple the size of the original cyst. So I would put the size at something like double of a normal cyst that I've shown on the left hand side. So what they've done is that they have simply mentioned chronic diarrhea in an AIDS positive patient, and then they have given an image of these cysts which are less than 10 micron with a marking given. Then it is obviously cryptosporidium, for which we will have to treat the patient aggressively. Otherwise, weight loss and HIV wasting will progress. On the right hand side, you can see rather a cyst which is two of them, and they are relatively bigger. So this would be a presentation that is seen with isospora. In both the circumstances, the answer to the treatment of choice will change dramatically, and that is their objective. For cryptosporidium diarrhea, the treatment of choice to be answered by you is nitazoxanide. Now we're talking about the treatment part. So nitazoxanide is the drug of choice for treatment of cryptosporidium diarrhea. But if he says Isospora belli is responsible for diarrhea where the cysts are relatively bigger in a modified ZN stain or Kinuan stain, then the answer should be given as cotrimoxazole. This is the third time that cotrimoxazole has been used, so I'll just summarize it once so that you can remember it for all. That is, one, cotrimoxazole is used in pneumocystis jirovecii. It is also used in cerebral toxoplasmosis, which is the important cause of seizures in a AIDS positive patient. And third is what is right now, that is Isospora belli. which can contribute to chronic diarrhea in a AIDS positive patient. These are three times where cotrimoxazole is used. Obviously, the perspectives of prevention and treatment are different, but that three times when cotrimoxazole is used in the patient for the GI perspective. Then we look at the CNS manifestations that can be seen in AIDS positive patients. The first one is to highlight regarding the cryptococcal meningitis part, obviously, but do not be under impression that we only have cryptococcal meningitis, because there are multiple other allied aspects to be seen. In the first image, which I'm now zooming in, I have tried to highlight for this MRI head of the patient presence of what is called as a soap bubble appearance. The moment you read this word, or if you see these multiple lesions like I have shown at the moment along with India ink preparation, then the diagnosis will become relatively simpler for you. Even if the India ink is not given, still these soap bubble appearance, which could be in any part of the brain, is a feature that is characteristic of Cryptococcus. This is obviously the India ink preparation that will show the capsulated organism. I'm saying even if it is not given, even then the soap bubble appearance is easy to pick up. Now you can easily get confused between this white lesions of soap bubble appearance in comparison to the second one, where you can notice a eccentric dot sign. This eccentric dot sign will be specific mainly to the basal ganglia area. So soap bubbles are present or are capable of being present anywhere, but especially if it is basal ganglia area, which is adjacent to the ventricles of the patient, if you get an eccentric dot sign, then the diagnosis should be thought in terms of cerebral toxoplasmosis. Clinical history will also play importance. If he gives you information of headache and a projectile vomiting in an individual with nuchal rigidity, and then gives you this MRI head, then you can obviously pick up that we are talking about cryptococcal meningitis. And exactly what he did in the exam was, he did not say that what is the diagnosis, which is very clear. He just said what is the radiological appearance, soap bubble appearance. On the other hand, if he talks about AIDS positive rickshaw puller and he's having recurrent episodes of seizures, and in this particular individual this eccentric dot sign is seen, then it is a diagnosis definitely of cerebral toxoplasmosis. We will test this person for antibodies against toxoplasma, and if he turns out to be positive to immunoglobulin G class of antibody, then we might have to use pyrimethamine and sulfadiazine in the patient. In the third image, you can notice the presence of hyperdensity in T2 image. The same hyperintensity is not present in T1, but in T2 some hyperintensity can be seen in some areas of the brain. So I'll describe this as subcortical hyperintensity. This subcortical hyperintensity is a feature that is usually seen in AIDS positive patients in T2 images with respect to the diagnosis as progressive multifocal leukoencephalopathy, which is seen with JC virus. And in the last image, you can notice the fact that I have shown a lesion which is like a space occupying lesion. You can see a huge lesion present, and it is associated with perilesional edema. So this would be a primary CNS lymphoma, PCNSL, which is a non-Hodgkin's lymphoma. So there are four aspects from the CNS manifestations that we just quickly have to go through. First is obviously Cryptococcus. The best test for diagnosis of cryptococcal meningitis is not India ink, but it is a CSF ELISA. For cryptococcal antigen, CRAG as they might use it, CSF ELISA for cryptococcal antigen. For treatment of this infection, the first line treatment would be liposomal amphotericin B, which can obviously damage the kidney, so KFT monitoring should be done with the 5-flucytosine. This treatment would be given for duration of 2 weeks, and once the patient is relatively better, the person will be discharged and he will then be given oral fluconazole for 8 weeks. So total treatment with cryptococcal meningitis will go up to a duration of 10 weeks, which is fairly long considering meningitis. Even in tubercular meningitis, we give treatment for obviously 6 months, but any other meningitis, usually treatment is given for 14 days only. The second aspect is that of development of seizures in an AIDS positive patient. One of the leading cause of seizures in an AIDS positive patient should be answered as HIV dementia. But HIV dementia is definitely a diagnosis of exclusion So the second possibility that you have to think is cerebral toxoplasma. There are two ways to identify the presence of toxoplasmosis in HIV positive patients. One, that you need to remember that if a person is having IgG class of antibody to toxoplasma, that means that the disease will be relatively more severe and encephalitis-like presentation can be seen in the patient. Second is this finding called as eccentric dot sign, which would be located only with respect to or mostly with respect to basal ganglia, unlike soap bubble appearance, which could be distributed evenly all over the brain parenchyma. The investigational choice is a combination of these two tests, and the treatment for this patient also is important. It would be most of the time given as cotrimoxazole for prevention purposes, and for treatment purposes it is pyrimethamine with sulfadiazine with leucovorin, as I've explained to you already. So I'll just use a short form after this, that is S stands for sulfadiazine and leucovorin. Due to high incidence of folic acid deficiency in the patient, if he says what is the test for diagnosis of progressive multifocal leukoencephalopathy, then again there are two things to be done. One would be we will be doing a PCR of the patient for CSF or JC virus, because JC virus is the villain behind development of progressive multifocal leukoencephalopathy. This virus lives in the kidney, but it can cross the blood-brain barrier and then it can cause damage in the brain. And second would obviously be a MRI evidence of a subcortical hyperintensity, which would be seen only with respect to T2 image. The subcortical hyperintensity location might vary, but most of the time is ascribed to the parietal lobe of the patient. And the fourth manifestation is primary CNS lymphoma, which is shown here. And if he says what is the test that you will do for identifying that it is a primary CNS lymphoma, then we will say that we'll go in for a stereotactic or a guided biopsy. The stereotactic biopsy will confirm the diagnosis of primary CNS lymphoma, and initially to reduce the cerebral edema component of the patient, we might have to use steroids in the patient as well. So these are the CNS manifestations which would be useful for or which are usually asked in the exam. So I thought I'll just speak about them, and the main objective of summarizing them all together is because I've talked about them at different times in the app in isolated format, but now since I'm talking about them together, so you can have a better outlook towards the common aspects which are asked for this particular infection. So we shall next talk about treatment for patients of AIDS, that is combination antiretroviral therapy. Now for management of this condition, there was a very landmark trial which is by the name of START trial. The findings of this trial were that if you start combination antiretroviral therapy earlier there were cutoffs like 350, prior to that cutoffs were 200, then they demonstrated in this START trial that early initiation of treatment is going to reduce the mortality rate to the tune of 50%. There is a cost benefit ratio to this also, in a sense that the amount of money that is required to treat a person with opportunistic infection, including the hospitalization cost, if you add up, the money invested is much more than as compared to the investment that the country or the health ministry will have to do to ensure a good healthy life for a HIV positive patient. This START trial has demonstrated that even if a person is having an acute opportunistic infection right now, like let us take up a patient who's having cryptococcal meningitis, and should we wait to start combination antiretroviral therapy when cryptococcal meningitis has resolved, or should you start the combination antiretroviral therapy immediately, was a question that was again answered by this trial, which demonstrated the fact that even if acute opportunistic infection is present in the patient, we are not going to wait for the opportunistic infection to clear, but if you start combination antiretroviral therapy early, then the possibility of survival of the patient will definitely increase. The logic here is that if you upgrade the immunity, then definitely the infection clearance will be better. But this aspect is not valid for cases of especially tuberculosis, and I have highlighted also multiple times that if a person is having TB with AIDS, then first you have to start anti-tubercular treatment, and then subsequently you have to start combination antiretroviral therapy, and a gap of 2 weeks has to be maintained. Why so? Because it was demonstrated that in a person who's having a combination of tuberculosis with HIV, if you will first give CART, obviously the immunity will be upgraded, but the upgrade of immunity will result in development of a complication that is called as IRIS. IRIS, as you all know, is called as The full form of IRIS is called as immune reconstitution. I would stand for then inflammatory syndrome. This basically in simple English means the fact that in the patient, when you start combination antiretroviral therapy, the immunity will be upgraded, but that will also produce cytokines. And those cytokines like interleukin 1 will reset the thermostat of the hypothalamus, and therefore person will start developing fever. So most patients are not going to understand the concept of cytokines and IRIS. They will simply say, sir, after your treatment, I get high grade fever. So why should I take the medicine? And therefore the dropout rates would be relatively higher. So considering this, the fact that IRIS can contribute to worsening of symptoms from the patient's perspective, especially fever part of tuberculosis will suddenly spike up. He will say, earlier I was having only low grade fever. I could feel it only in the evening hours, which is obviously a perception on the part of the patient. But now he is saying that my fever part has increased, my symptoms have increased, my cough has increased. So he might actually drop out of treatment, and that is why apart from tuberculosis, in any other opportunistic infection, you can start the combination antiretroviral therapy immediately. But do remember this part for tuberculosis, that there should be a time lag of 2 weeks. Now for the guidelines, there are recommendations that at least 3 medications should be given to patients who are having AIDS simultaneously, which should be from 2 classes, and I'll be explaining these classes of drugs to you in my subsequent slides. And before you initiate treatment, 2 things are must know from the part of the physician's perspective. One, you need to know the viral load in the patient, that you will check for HIV PCR RNA, and the report will tell you how many million copies of virus are circulating per ml of blood. And obviously when you will treat the patient, the viral load should definitely reduce, and the objective is to make it as low as 0. Now obviously the technique of PCR may not be able to pick up 0, but the current PCRs are sensitive enough to identify less than 40 copies per ml of blood. So that's our objective: downgrade the level of virus in the blood. And simultaneously another test that must be done on initiation of treatment is resistance testing, because you might have to modify the treatment subsequently. And one of the common mutations which is found and is responsible for drug resistance is K103N mutation. This will specially result in development of resistance to non-nucleoside NRTIs, that is non-nucleoside reverse transcriptase inhibitors. So do remember this mutation, which is usually found in 10% of American population as far as CMDT is concerned. So a question to this effect can be asked, that which mutation would be responsible for resistance with respect to HIV. I would also like to draw your attention to a similar kind of question which has been asked in chronic myeloid leukemia, which is regarding T315L mutation. This mutation, which is encountered in patients of chronic myeloid leukemia or CML, will make the person resistant to both first line and second line tyrosine kinase inhibitors. So the drug that we use for management of this is called as ponatinib. This I have covered in the hematology section, but since the aspect of resistance came up, I thought I'll just remind you of 2 mutations. The names are T315L and then K103N mutation with respect to AIDS, which causes resistance to especially NNRTIs. So that obviously has to be kept in our mind. Now, when we look at the categories of drugs which are available for management of this particular condition, one category of drug that we will first study is called as nucleoside reverse transcriptase inhibitors. So I'll just write it like this. With the first drug, that is by the name of diadenosine, one of the biggest side effects that is asked for this drug is presentation of obviously peripheral neuropathy. The second complication which is seen with this drug and is important is pancreatitis. In fact, that's a standard question that they used to ask earlier. Now the incidence of this question has reduced, obviously, because diadenosine is not used in most of the protocols. But why it has come out of use is because of 3 side effects, which are peripheral neuropathy, pancreatitis, and hepatitis. And some books mention even our development of fulminant hepatic failure. So considering the side effect profile of peripheral neuropathy, pancreatitis, and hepatitis, this drug is not recommended in the current protocols. The second drug by the name of stavudine will also contribute to the same complications, that is peripheral neuropathy, pancreatitis, hepatitis. The additional aspect which is seen as a complication with this is lipoatrophy. Remember the fact that with protease inhibitors you read the word lipodystrophy, but with stavudine you read the word lipotrophy, so that words obviously have to be remembered. Zidovudine was the first, AZT is the short form for it. It was one of the first drugs that was introduced for management of patients of AIDS, but obviously now the usage of this is not recommended because of obviously the side effect profile and the frequent dosing that is required with this medication. So the two side effects with this are anemia and neutropenia. The two side effects with this drug are anemia and neutropenia. With abacavir, one of the biggest problems is that you need to do testing. The testing should be done for HLA-B5701. Why it is important to do this testing is primarily because of the fact that there could be a possibility of anaphylaxis associated with the drug. So let me explain. Abacavir can contribute to development of rash, and rash is obviously common with most of the anti-HIV drugs. Normally what happens is that as you continue with the drug, the person's body gets used to it and the rash also tends to decrease. But with this drug per se, the severity of rash keeps on increasing. So most of the time what a physician will do is that if a person is having a severe rash after intake of the drug, that is an allergic manifestation, the physician will stop the drug for a few days, and then when he will reintroduce the drug, he will think that most of the time the side effect may not occur or may occur with less frequency. But with reintroduction of abacavir, it has been seen that suppose you stopped it because the person was having a severe evanescent rash, now when you reintroduce the drug, anaphylaxis can definitely develop. So that's again a MCQ statement for you, that which anti-HIV drug is capable of causing anaphylactic shock, and a testing for this is mandatory before it is introduced. The answer would be given as a nucleoside reverse transcriptase inhibitor, that is abacavir. The remaining two drugs, emtricitabine and lamivudine, are relatively safe. Obviously, all drugs have some side effects. I have talked about the MCQ one important ones on the top, and for emtricitabine, lamivudine, what I want you to remember is that they can also be used in patients who are having both HIV and hepatitis B. So in case there's a co-infection with hepatitis B, then both these drugs are working. In fact, tenofovir, emtricitabine and lamivudine, all the three drugs would be working even if the person is having a co-infection with hepatitis B. Moving to the next category, which we have to remember here, is called as non-nucleotide reverse transcriptase inhibitors. Now, when it comes to non-nucleoside reverse transcriptase inhibitors, the first one that is mentioned here is dilavedine. This requires very frequent dosages. So this drug is rather rarely used. The main reason why it is rarely used, I said, is because of the inconvenient dosaging. So as such, it is unlikely that they'll put up a question on the side effects of this drug, which can range from obviously damage to the liver, elevated transaminase levels in an individual. The second drug which is remembered or to be remembered is efavirenz. Now this is to be remembered because of the neuropsychiatric manifestations which are associated. The question that can come on this would say that which anti-HIV drug increases the risk of suicidality in the patient. Then the answer is right in front of you, that is efavirenz. So neuropsychiatric complications have to be taken care of. We can also have development of resistance to these non-nucleotide reverse transcriptase inhibitors, as I was saying initially. So the drug that can be used in case you have resistance to the remaining drugs which are written here like nevirapine or rilpivirine is etavirin. This is mentioned in the textbook as a second generation non-nucleoside reverse transcriptase inhibitor, and this is recommended to be used or can be used in case there is a documentation of a resistance. For nevirapine, well, one, you would be all aware of a single dose nevirapine that is recommended in a HIV positive lady. Like if she comes to a government hospital at the time of labor pain, then a single dose nevirapine is to be given to the lady at the time of delivery and then to the baby within 72 hours of birth. That will reduce the vertical transmission of HIV in an Indian setup, because the vertical transmission for HIV is close to 30%, so you can downgrade it with help of nevirapine. But yeah, long-term usage of nevirapine definitely has its own aspects of problems, ranging from rash and hepatotoxicity. So you can see the fact that why in the initial workup was I vocal about using LFT on a regular basis for the patient. That's mainly because most of the drugs that we are using here can contribute to increase in the level of the enzymes of the liver. Though if you are using high dosages of the drug, even fulminant hepatic failure has been reported, like for example with diadenosine. So normally you will see that with the current guidelines, integrase inhibitors, which I'll be explaining to you, are the ones which are now being used as first line drugs for management of patients of AIDS, because the safety profile of integrase inhibitors is much better as compared to the profound side effects that are associated with this particular category of drugs. The next category to be remembered here is by the name of nucleotide reverse transcriptase inhibitor. This category will be having only a single approved drug, that is by the name of tenofovir, and there are two forms of tenofovir. One is by the name of tenofovir alafenamide, which is usually written as TAF, the short form of it, and the second one is tenofovir disoproxil fumarate, which is written as TDF. So I can say the fact that the same drug is having two derivatives, and the two side effects with respect to this drug would be, one, that it can contribute to damage to the kidney, so serum creatinine monitoring obviously has to be done, and secondly, this can also be causing damage to the bone matrix. So two side effects of this drug, the damage to the kidney, damage to the bone matrix, is to be remembered, and this is the only approved nucleotide reverse transcriptase inhibitor. The advantage with this is dosing, and the second advantage with this would be that this is also active against hepatitis B. So three drugs that are effective against hepatitis B are tenofovir, then is emtricitabine and lamivudine. Subsequently, we will study regarding protease inhibitors. Protease inhibitors are important because once the virus will be formed inside the CD4 cell, the proteins which are formed are relatively long templates. So though they have to be spliced, they have to be broken into smaller components like P17, P24, and then assembled to form a baby virion. So the function of the protease enzyme is basically the assembly of the baby virion, and a protease inhibitor will prevent the same from happening. With respect to azatanavir, we need a boosting. You would have mostly seen that with almost all the protease inhibitors, boosting is recommended. So the booster that is required with azatanavir is Cobistat. Another one is darunavir, that is the booster that is required is ritonavir. So you will obviously notice ritonavir boosting always written with most of the protease inhibitors. In fact, why it is written is because this will inhibit cytochrome P450, and therefore it will reduce the metabolism of the remaining protease inhibitors. So the side effects which are encountered again with these two drugs is development of liver damage, jaundice, and rash. That's the standard profile with all of them. With respect to indinavir, extra side effect that would come would be development of kidney stones, which would be having indinavir crystals. So stone formation is seen with was again a question that is with indinavir. The remaining of them are mainly responsible for GI complaints. And a common side effect for all of these drugs is development of lipodystrophy. Earlier I was saying lipoatrophy, but now I'm saying lipodystrophy is noticed with all protease inhibitors. So that is why lipid profile will be done initially for our patients. And lipoatrophy, as I told you, is seen with stavudine. So these aspects are, though studied by you in pharmacology, I just thought that I introduced you to the category of drugs before we proceed forward. The next category that we will talk about is called as entry inhibitors. They are also referred to as fusion inhibitors. The enfuviritide molecule is given subcutaneously in the form of injection twice a day, so obviously the compliance part would be affected. And well, how would maraviroc be acting? Then I've spoken regarding CCR5 co-receptor, which is important for fusion of the virus with the CD4 cell. So if you affect the co-receptor, then the entry part and the fusion part will definitely be hampered. One of the latest categories and is being effectively used for management of AIDS nowadays is integrase inhibitors, and the side effects with these drugs are very limited. So considering the fact that the safety profile is good, the side effect profile is relatively better, and the viral load decreases proportionately, therefore integrase inhibitors are obviously a part of once a day pill that is recommended for management of AIDS. And obviously, like you can see, like if I tell somebody that one medicine to be taken twice a day, another to be taken thrice a day, another to be taken maybe once a day, so when you tell so many tablets to a patient, most patients are gonna make a big face and say, doctor, don't you have a tablet which I can take once a day? So nowadays the focus is on once a day regimens for management of patients of AIDS. So let's now look at what are the once a day regimens which are recommended for our patients, and therefore the survival rates will dramatically jump up. We shall now be talking regarding once a day pill for management of patients of AIDS. And when you tell a patient that the tablet has to be taken only once a day, then the interest of the patient will definitely be increased, since the emotional trauma with respect to taking a tablet multiple times per day versus once a day is relatively lesser. I mean, if I put it on myself, if a doctor tells me that you have to eat 6 tablets in a day, once in the morning, once in the evening, another tablet to be taken after lunchtime, so it will make me feel as if I'm sick most part of the day. But with this, definitely the interest of the patient will be there, and therefore you are seeing nowadays that the longevity of these AIDS patients has increased dramatically. With respect to the first drug that has to be remembered, the molecule is an integrase inhibitor by the name of dolutegravir. Along with this, we will be using abacavir, which is a nucleoside reverse transcriptase inhibitor, along with lamivudine. I have explained to you that total of 3 drugs are to be used in management of patients of AIDS, and 2 categories should be there. So here the categories that have been discussed are integrase inhibitor, and second one is nucleoside reverse transcriptase inhibitor. Because of obviously the anaphylaxis risk, instead of abacavir, we can use an alternative molecule by the name of emtricitabine. And in place of lamivudine, we can use tenofovir. Tenofovir is in 2 formats. One is called as TAF, the second one is called as TDF. I've explained to you that tenofovir alafenamide and second one is tenofovir disoproxil fumarate, and the safety with respect to damage to the kidney is lesser for tenofovir alafenamide, that is TAF. So that is why I have written a short form here. The third molecule which can be used for management is by the name of L-vitegravir. Along with this, emtricitabine and TAF would remain common. So you can see that integrase inhibitors, they can be used in permutation combinations with multiple other drugs. These are 3 once a day pill. The 4th regimen that I'm telling you, in this raltegravir is the one which is to be taken twice a day. But the remaining 2 tablets would be emtricitabine and tenofovir, that would be once a day tablet. So these are the regimens with which the clinical experience is relatively good. So that is why I have basically explained to them. Now suppose a patient is not able to tolerate integrase inhibitors. Though that is relatively less common, but I'm saying just in case a person cannot take integrase inhibitors or is intolerant to integrase inhibitors, then we also need to have a backup available. So what is the once a day protocol available in case of those who are not able to take these molecules are a combination of efavirenz along with the emtricitabine. I'll just write the full form once again so that I can just make you remember it. And the third molecule is obviously tenofovir, but this time it is tenofovir disoproxil fumarate. So this regimen is one which is commonly known by the brand name ATRIPLA, and a lot of physicians have a good experience with this. In fact, CMDT says that the longest clinical experience with respect to once a day pill at the moment is with respect to the protocol that I've mentioned here before you, that is efavirenz, emtricitabine and TDF. So this is recommended, however, in those patients who cannot recommend the protocols written above. So whenever you will read about the treatment for patients of AIDS, these are the standard protocols which are recommended. Though the NACO guidelines might vary a bit, this is what CMDT is saying. So that is why I have spoken about these. The next aspect to be remembered is what is to be done if a doctor is exposed to HIV infection, because in case there is an accidental needle stick injury, then the chances of a doctor getting infected are close to 0.3%. Even if a doctor is using gloves, you see the cutting edge of the needle is sharp, so the chances of infection are definitely there, especially because nowadays when we are working, we don't know the actual status of the patient. So the management of these patients would be with help of post-exposure prophylaxis, and the post-exposure prophylaxis should be used within upper limit of 72 hours. But the question was, it should ideally be started within. So there was a lot of controversy regarding whether it should be started. Answer should be 72 hours, or options were like 1 hour, 2 hour, 4 hour and 72 hours. So upper limit is obviously 72 hours. But here the question was, ideally it should be started. What is the lower limit in which it should be started? So the lower limit is within 2 hours, and obviously a lot of people, when I said 2 hours, they asked me for reference. So I have this NACO 2018 guidelines which clearly mention the fact that post-exposure prophylaxis, the first dose should be started ideally within 2 hours and certainly within an upper limit of 72 hours. So both these aspects have to be remembered. And if you start after 24 hours, then the obviously the efficacy of the molecule will definitely go down. So I'll just write it for record's sake, that is ideally within the first 2 hours, and then it is not effective after 72 hours, and then let us study regarding the drugs which are used for post-exposure prophylaxis. Here again the problem is that the NACO guidelines are slightly different from what CMDT says. So I will first mention regarding what CMDT says for management of a person who has had a occupational exposure. One of the molecule which is recommended is tenofovir, obviously, with emtricitabine and raltegravir twice a day. In fact, I was speaking about this regimen just a little bit earlier only. So the guidelines are that he says that you should use 3 drugs and you should treat the person as aggressively as you would treat a person of AIDS. You see, it's not that he's a fellow physician of mine. It is just the fact that because the chances of seroconversion are there to development of AIDS, so why to take a chance in an individual? You have to treat the person as aggressively. But when it comes to NACO guidelines, they are actually mentioning 2 drugs. So I would like you to remember both the aspects. One is tenofovir, emtricitabine, and raltegravir, which was one of the regimens that I mentioned earlier. Or for that matter of fact, what if they specify the word NACO guidelines? Then the NACO guidelines mention only usage of 2 drugs. The 2 drugs which are recommended are tenofovir and lamivudine. He does mention about 3 drugs at the bottom of the table, but usually, especially the PSM teacher would have talked about this only. So I would definitely like you to remember both the aspects. That is, the NACO guidelines would be tenofovir, which is common between the CDC guidelines and NACO, that is tenofovir and lamivudine. And the inferior one, as I've shown you, is tenofovir with emtricitabine and raltegravir. So the controversy will be between 2 versus 3 drugs. But I think this controversy is best left to rest, because if he gives you among the options, I would personally suggest you to answer according to what CMDT is saying, not because I want to discredit what NACO is saying. I'll put it like this: even NACO in the bottom of the table have mentioned regarding usage of 3 drugs only, and they have tried to differentiate whether it is a mild exposure or a moderate exposure or a severe exposure. And it is very difficult actually in clinical practice to differentiate between what is a mild and what is a severe exposure, because a prick is after all a prick. You just can't say that it is a superficial prick versus a deep prick. If it's a fellow doctor of yours and his life is at stake, I would go out with all guns blazing. I'll be trying to be as aggressive as possible, and I would like to give a 3 drug combination for the patient. So I would recommend you, if you are stuck in a situation between 2 drug versus 3 drug for PEP, then I would recommend 3 drug to be answered in the exam. So these are the treatment aspects which are to be remembered. That is, one, I have highlighted regarding the once a day pill for management of AIDS. These are the standard molecules which we shall be using, and for post exposure prophylaxis also we can use the last one, that is the 4th one, or a 2 drug regimen of tenofovir and lamivudine for the patient. So these are details, guys, which I want you to understand for AIDS, and keep on studying well, and you're doing well in your progress, but keep on doing questions on a regular basis so that your performance part is upgraded. Thank you so much for listening.